Good evening. Thank you for joining our town hall tonight as we take a look at COVID-19 1 year later. I'm Debbie Carlson, Chief of Staff at Community Memorial Health System. Tonight, I will be joined by several of the medical leaders here at CMHS who will be providing a complete update on COVID-19. We welcome your questions. During the presentations, please utilize the chat feature to type in your questions, and at the end of our presentations, we will answer those questions as time allows. Before we start, I would like to pause to acknowledge everything we have experienced this past year and personally thank our physicians and staff here at CMHS who have been working with skill and compassion to take care of our community. I am proud to be a part of this amazing group of individuals. First, we'll be hearing from Gary Wild. Mr. Wild is the CEO of Community Memorial Health System and past chair of the California Hospital Association. He is here this evening to discuss where we are today with the COVID-19 pandemic, new variants, and the outlook for a potential fourth wave. Please welcome Gary Wild.
Debbie, thank you, and welcome everyone. I'm going to share my screen because it's easier to show what has happened over the last year by these graphics. I trust you can see that. First of all, for the United States, this slide is updated today, and this shows in this red diagram here the number of new cases since a year ago until present. As you can see, it was going straight up after the holidays, and it's now going straight down. There are, if you can see and discern this, three separate bumps or surges. One was at the very beginning of the pandemic. The second one was right after the 4th of July holiday. And the third one, the largest, was following the holidays. California numbers are very similar. The same three surges, and it was going straight up after the holidays, and gratefully it's going straight down, as are the number of new cases, the number of deaths, and sadly we have exceeded over 500,000 deaths in the United States and about 51,000 as of today in California. Hospitalizations are also down. Here at CMH, we peaked at about 100 COVID positive inpatients, and this morning we were down to 21. So a quick vaccine update. Right now, this is a map of the United States. The darker the color, the higher percentage of the population that have received at least one dose of the vaccine. So California is about in the middle. We're about 14%, 13.6% as of today. But gratefully, Ventura County is about 20%, 19.9%. So as of yesterday, we had some vaccine clinics today. So we're moving in the right direction. We want that number to be much higher, of course. And this just shows the number of new doses, and you can see that we are hoping that these graphs would continue to go up and even accelerate, but they've actually diminished a little bit. The supply has not kept pace with demand. But by the end of July, the three major manufacturers have committed to have at least 600 million doses available for the United States, at which time we hope that we can vaccinate everyone who wants to be vaccinated. So what keeps us from declaring victory at this point? First of all, like I said, the vaccine distribution has been slower than desired. California's anticipated allocation has only been 2/3 of what we thought it would be. We were getting now about 118,000 doses per week. We were hoping to get 180,000. We also have phased priority tiers. I'll talk about that in just a little bit. And then, as Debbie indicated, there is a potential for a fourth surge. We also have variants that are dominating the news today. I think Dr. Ali Schumann is going to talk about that in a little bit of detail. So these phase tiers are prioritizations of who should get the vaccine first, and there's controversy with this, as you might expect. Phase 1A were healthcare workers, particularly frontline healthcare workers, the doctors, the nurses, the staff working in the ICU, the emergency room, and so forth. Phase 1B were those individuals, everyone over 65, and also essential workers, which have just started this week. We had a clinic just today, and another one will be tomorrow to begin vaccinating food service workers, people in agriculture, teachers. Importantly, we are going to be providing a vaccination clinic for all the teachers in the area, childcare workers, and emergency services. And these vaccinations are happening right now. In Ventura County, there's been over 168,000 vaccinations to date. Beginning March 15th, at least that's the projection, we'll begin vaccinating those that are 16 through 64 with severe health conditions. And those are defined, if you'd like to go to vcrecovers.org, you can see these tiers and get the definitions. And then the next phase is everyone else, and hopefully through the end of July, everybody who wants to receive a vaccination, at least one dose, will be able to get it by the end of July. You hear the news about variants. And in the United States, as of today, according to the CDC, and there are 3 variants. The first one is called the so-called UK variants from the United Kingdom. To date, we've identified 1,881 in 45 states. The South African variant, 46 in 14 states. The Brazilian, 5 in 4 states. So you can see, although there's a lot of discussion about it, there haven't been high numbers compared to the regular coronavirus. What about the future? Pfizer and Moderna have already have the ability to tailor the vaccine, the protein spike, for variants that may come in the future. And so that's good news. And it may be, this is my speculation, but it may be that there will be an annual COVID vaccine in our future along with the seasonal flu. So the vaccines that have been approved, at least for emergency use by the FDA in the United States, include Pfizer, Moderna, and if it hasn't happened today, it'll probably happen tomorrow or the next day. It's an imminent approval for the Johnson & Johnson. They vary a little bit. Pfizer and Moderna are very close and similar. Each has about 94, 95% efficacy rate. Both require 2 doses about 3 weeks apart. The Pfizer vaccine needs to be kept in an ultra cold environment, minus 70 degrees Celsius, in dry ice or a special refrigerator. And as I say, it's been approved. It is effective in the B117 variant. This is the UK variant, but it has lower protection for the others. It's unclear about the Brazilian because it's very new. Moderna, same situation, and Moderna is a little bit easier for outpatient pharmacies. They don't have access to the ultra cold freezers like many of the hospitals do. And then finally, Johnson & Johnson, while it's only 72% effective, the benefit of this one is it only requires cool storage. A regular refrigerator in a pharmacy or a clinic or a physician's office would be more than adequate to keep it in storage. And it only requires 1 dose. Like I said, the approval is imminent. AstraZeneca and others are in the pipeline. So the question is, which vaccine is best? The best one is probably the one for which you can get an appointment, to be honest. So that's what I wanted to share this evening. And Debbie, I'll turn the time back to you. Thank you.
Thank you, Gary. Next, we'll be hearing from Dr. Neil Canby. Dr. Canby is an emergency physician at CMH and medical director for the Ojai Valley Community Hospital's emergency department. This past year, the bulk of his time has been spent working with CMHS to address the pandemic as the chair of our Disaster Preparedness Committee. Tonight, he will be discussing outpatient treatments that have been approved and researched throughout the pandemic. Which ones work, which ones don't, and which ones we are currently investigating. Neil, welcome.
Neil, you're on mute.
The mantra of 2020, 2021, I was on mute. Sorry about that, guys. So, well, I'll start over. Yes, my name is Neil Canby. I'm one of the emergency room physicians here at Community Memorial Hospital and the Ojai Valley Hospital. And as Deb stated, I am the Disaster Preparedness Committee Chairman. And we meet on a regular basis. And, before COVID came, we were more focused on natural disasters and earthquakes and power outages and how we were going to get through that. And we talked a little bit about emerging infectious diseases. We thought a little, we talked about Ebola and Zika up until last year, and then obviously that all changed. So tonight, Deb's asked me to talk about outpatient treatments for COVID-19. Throughout the course of the pandemic, there have been a lot of various treatment options that have been put forth and discussed. Some seem reasonable, others maybe not so much. One of the main messages we wanted to provide tonight to everyone out in the audience is that the medical staff at CMHS practices what we call evidence-based medicine. We offer treatments for our patients that are grounded in science and backed by research that has shown that those treatments are safe and effective. The National Institutes of Health has an advisory panel which develops these COVID treatment guidelines, and their recommendations are either that it is recommended for their use or states that it is not recommended, or main category is that there's just insufficient data to recommend either for or against at this time. So 1 year into COVID-19, where do we stand? To be honest, we really pretty much started without very much. We had what we kind of do, supportive care for viral infections. Early on in the pandemic, the thought was brought forward to see how hydroxychloroquine or chloroquine might work in the treatment for this. These are anti-malarial drugs that were developed in 1930 and 1950. They're currently used to treat lupus and rheumatoid arthritis along with malaria. There were thoughts early on that this could help prevent the virus from either entering the cell or being able to actually copy itself. The FDA granted what's called an emergency use authorization in April of 2020, allowing hydroxychloroquine to be used for the treatment of COVID-19. This was done in the absence of any randomized double-blind controlled studies that evaluated its true efficacy. Two major studies were subsequently done: Solidarity, which was run by the World Health Organization, and Recovery, which is the randomized evaluation of COVID-19 therapy, which was done at Oxford University in the United Kingdom. These studies showed that there was no benefit from hydroxychloroquine or chloroquine in the treatment of COVID-19. The FDA revoked its EUA for hydroxychloroquine in June of 2020, and the National Institutes of Health no longer supports the use of it for the treatment of COVID-19. There are some studies ongoing regarding its use in the prevention of COVID-19, but again, this is not recommended for the treatment anymore. Another treatment option put forward early on in the pandemic was the use of the antibiotic azithromycin. Many of you in the audience may have taken this in the past for community-acquired pneumonia, or for those of you with asthma or COPD for bronchitis associated with that. Some people commonly call it a Z-Pack. There was some evidence in the past when we were dealing with Ebola and Zika that it might actually help with viral transmission. However, this antibiotic was also evaluated during the recovery trial, where they had about 7,000 patients that were randomized to either receive azithromycin or placebo, and it was found to be non-beneficial. Other treatment options as an outpatient, dexamethasone. So dexamethasone is a corticosteroid that decreases inflammation, which is the major component after a coronavirus infection that develops the acute respiratory distress syndrome that goes along with that. Again, during the recovery study, they clearly showed that dexamethasone helped in hospitalized patients requiring oxygen. However, the use of dexamethasone for those patients with mild to moderate disease, not hospitalized and not requiring oxygen, actually increased their mortality. So for this reason, the NIH does not recommend dexamethasone or other corticosteroids at this time for routine use as an outpatient. So moving along, we haven't had much success so far. Now we're leading up to antibodies, and there's been a lot of publicity about antibodies for outpatient treatment. We have kind of two sources of antibodies, those that are naturally occurring and recovered from patients who have recovered from COVID, and that's called convalescent plasma. And the others are monoclonal antibodies, which are made in the laboratory. The convalescent plasma has to be given in the hospital, so I will defer that to Dr. Bernstein as an inpatient treatment option. But as far as monoclonal antibodies, these can be administered as an outpatient. These antibodies, they're IgG in nature, are made in the laboratory and can be infused back into your body to help prevent severe infections. The initial studies by the pharmaceutical companies showed that these monoclonal antibodies actually did not help with patients that were already ill and already hospitalized. So they kind of circled the wagons and went back and looked and thought, well, what if we give them early before you were hospitalized? Could they prevent you from becoming significantly ill? So the early data from manufacturer Lilly and their product, and this is where the tongue twisting comes along, bamlanivimab is one of the names of the monoclonal antibodies, and they did a trial called the BLAZE-1 study. And in the phase 2 portion of that, and not to get too technical there, it did show that they could decrease your risk of hospital admission. And they decreased the risk from 6.3% to 1.6%. So a relative reduction there of about 74%. And so, they kind of went forward with that. There were some side effects from this. There were some common, nausea, diarrhea, vomiting, and some itching. There was concern about allergic or anaphylactic reactions. 2 out of the 850 people that they were in their phase 2 study required treatment with epinephrine, which is a strong medication we use to treat an anaphylaxis, but no one died from that. And then the other limitation of this is, other than the decrease in the risk for hospitalization, they couldn't really draw any other conclusions regarding the severity of your disease or your overall outcome. Regeneron is another manufacturer, and they have 2 monoclonal antibodies in a cocktail that they kind of call it there. And their data is very similar to that of Lilly's and the bamlanivimab. At CMH, we've been using the bamlanivimab here in our outpatient setting in the emergency department. But based on the above data for the monoclonal antibodies, the FDA did issue an emergency use authorization for the use of monoclonal antibodies for the treatment of mild to moderate COVID-19 in adults and pediatric patients, so 12 years in age or older. You have to weigh at least 40 kilograms. You have to have had a positive COVID result, and you have to be within 10 days of the onset of your symptoms, and be at high risk for progression to severe COVID-19 and or hospitalization. Now, what do they describe as high-risk patients? So here's a kind of a list. I'll run it down here. They have to have a high body mass index, a BMI of greater than 35, so basically severely obese, have chronic kidney disease, diabetes, have an immunosuppressive disease, or currently receiving immunosuppressant treatment, be older than 65 years of age, older than 55 years of age and have cardiovascular disease, hypertension, COPD, or other chronic respiratory disease. If you're between the age of 12 and 17, and have the core requirements there, again, obesity greater than 85th percentile for their age and gender, history of sickle cell disease, congenital or acquired heart disease, neurodevelopmental disorders, for example, cerebral palsy, or a medical related technological dependence. For example, if you have a feeding tube or a tracheostomy, you're on a ventilator, that puts you at high risk. And also if you have asthma, reactive airway disease, or any other chronic respiratory disease that requires any daily medication control. So they did issue the EUA. However, the NIH currently, because of the data is kind of limited, states that there's insufficient data to recommend either for or against the use of these monoclonal antibodies. So it gets a little confusing there. So Lilly went back, and actually this just came out about 3 weeks ago. They came out with a second monoclonal antibody that they add to their cocktail, similar to what Regeneron did, but they have estimimab. And please don't ask me to pronounce that many more times. But they add the estimimab along with the bamlanivimab, and this combination showed much better evidence that it could prevent worsening disease. And what really helped here was they had more patients and it had more power. And they had a relative risk reduction from 7% to 2%, but they could also show that it decreased death. In the two control groups, or the two groups where there were about 517 and 518 patients, there were 10 deaths in the placebo group and no deaths in the test group. So this actually led the NIH to change their recommendation for the use of the bamlanivimab and the estimivimab cocktail, where they actually gave it a recommendation. Now with this new recommendation and new medication as of February 9th, it's not currently available. As soon as it does become available, we will offer that to those who qualify through the EUA. And at CMHS, we are currently setting up a process through our infusion center to provide this treatment as needed. Now, with all that news being said there, the NIH still recommends that healthcare providers discuss the potential benefits and risk of the product as part of a shared decision-making, because these treatments are still considered experimental and they are not the standard of care for treatment of patients with COVID, and that patients with COVID-19 admitted to the hospital should not receive these treatments. So moving along here, we've got a couple more things to talk about. One of the other topics, or one of the other treatments that's come popular lately is vitamin D. So they did some studies about vitamin D and how vitamin D deficiency seemed to be a common denominator for some of the people that were very severely ill with COVID. They share many of the same risk factors, including increased age, Black or Hispanic ethnicity, and obesity. And so they looked at some of these patients and said, well, is it the vitamin D, or would that help? And unfortunately, at this point, the data is still limited. They haven't been able to state one way or another, so I say that there's insufficient data. But as of February 18th, which was just last week, JAMA published an article from a study in Brazil where they had equal groups in a randomized controlled study in an ICU where they administered vitamin D, and unfortunately, it didn't really show much benefit. So one or two more things I want to talk about tonight. Ivermectin. This is another already approved FDA drug used for the treatment of parasitic infections. In laboratory tests, it's been shown to been able to inhibit the replication of the virus in the cell, or I'm sorry, in the laboratory. However, it takes a much higher dose, almost 100 times higher than the current allowable dosage to achieve this level to stop this action. Initially, the NIH had a recommendation against the treatment of COVID with ivermectin. There were some studies that were ongoing and some data that preliminarily, and in January, they changed their stance to that there's insufficient data to either recommend for or against the use of ivermectin at this time. And as more studies are coming out, there's some retrospective studies and have been published in peer-reviewed journals. Some studies show no benefit or worsening of disease after ivermectin, and there's others that have reported improvement, including lower mortality rates. Unfortunately, some of these studies have incomplete information and significant methodological limitations, which makes it difficult to exclude some common causes of bias. Currently, there's 11 trials that the NIH has evaluated so far, and there's another 45 studies currently ongoing. And as more evidence is obtained, we'll be able to make a better recommendation whether ivermectin will be a promising treatment or not. So in summary, unfortunately, we don't have that much to offer as outpatient treatment for COVID-19 at this time. We're not much better than we were when we started. Monoclonal antibodies are showing promise. We need to get a little more data on vitamin D and the ivermectin. And several studies showed no benefit or harm, including those regarding the hydroxychloroquine and chloroquine, the dexamethasone as an outpatient, and azithromycin. All right, appreciate your time and attention. I hope that clarified a few things of what we have for outpatient treatment, and I'll turn it back over to you, Deb.
Thank you, Neil. As a reminder, we'll be having a question and answer session after the presentations. If you have a question, please enter it in the chat box at any time. Up next is Dr. Robert Bernstein, who will be speaking on current therapeutic options for treating COVID-19 patients in the hospital. Dr. Bernstein has been an active member of the medical staff at Community Memorial Hospital for over 20 years. He specializes in the practice of respiratory disease and critical care medicine. Bob, thank you for joining us.
Thank you, Debbie. And a thank you to all of you out there for participating in tonight's event. As a physician specializing in the care of people with respiratory disease, I am all too familiar with the heavy toll that COVID-19 has had on individual patients and the community at large. Nevertheless, I am hopeful and optimistic that this disease can and will be subdued in the coming months through the concerted efforts of our community members and healthcare system. I've been asked to speak about current therapeutic options for treating COVID patients in the hospital. So who among those infected with COVID-19 need hospital care? Well, hospital care is necessary for those people who are too ill to recover on their own. These are people who either have a low blood oxygen level or have other indicators that suggest the need for nursing care, monitoring, and medical treatments that cannot be given at home. Fortunately, hospitalization rates in Ventura for COVID-19, as well as around the state and country, have sharply decreased over the past few weeks. And while needing to be hospitalized for COVID-19 infection is a concerning situation, keep in mind that most people who are hospitalized are ultimately discharged home. However, about 1 in 7 who require inpatient hospital care become seriously ill. In our experience and the experience of others, those whose illness progresses to the point of needing a breathing machine have a poor prognosis. That being said, based on reports from medical centers in the US and abroad, it seems that the risk of dying among hospitalized patients with COVID-19 infection has recently declined significantly. This is probably due to knowledge and experience gained over the past year in treating this illness, rather than a change in the biology of the virus itself. So what can we do as medical professionals at the community mobile health system for people admitted to the hospital with COVID-19 infection? Well, there's the basics: nursing care, observation, and oxygen therapy. These interventions alone reign supreme among the treatments that are available to treat this illness. Physician and nursing knowledge of when and how to escalate care to a higher level and when to step things down is crucial to successfully navigating this disease. Then there are medications, our tools in our toolbox, which when applied properly can help. We practice in accordance with updated guidelines provided by the National Institutes of Health and the Infectious Disease Society of America, looking to the nation's best and brightest minds to help inform us on the best treatments available. Our best treatments, when used properly, currently include anti-inflammatory steroids like dexamethasone and the antiviral antibiotic remdesivir, as well as blood thinners to treat and reduce the risk of blood clots. We are also selectively using tocilizumab, that's an anti-inflammatory monoclonal antibody, in critically ill patients who are early in their ICU stay and who are worsening. CMH has gone the extra mile to ensure the safety of patients and staff by taking comprehensive environmental efforts and measures to virtually eliminate the risk of spreading the virus in our facilities, including strict adherence to antisepsis and enhanced ventilation in patient rooms. Member leaders of the medical staff of Community Memorial Health System have been meeting and collaborating with each other, nursing staff, and the health system administration on virtually a constant basis, working behind the scenes to keep up with and keep ahead of the challenges of caring for our sickest patients, including adopting the latest proven medical therapies, infection control measures, and planning otherwise to ensure your health. It is my sincere hope that you will never require hospitalization for treatment of COVID-19. But if you do, we are ready and able to provide the best care that you need at CMH. Thank you. Debbie, back to you.
Thank you, Bob. Our last speaker tonight is Dr. Allison Schumann. Dr. Schumann trained in pediatrics and pediatric critical care at New York Presbyterian Hospital and is double boarded in general pediatrics and pediatric hospital medicine. She has served as the medical director of the pediatric hospitalist program at CMH since 2013. She will be giving us a vaccine update, speaking on the types, their efficacy, and their safety. Allie, welcome.
Thank you, Debbie. Welcome everybody who's on with us tonight. So what I'd like to do is to take my time to go a little bit through information about vaccines for COVID, some of which you may already know and maybe a review, and some of which may be new. But first, I want to talk a little bit about the different types of vaccines that are available for COVID. So generally right now, there are 2 types of vaccines that are either on market or coming to market. The most well-known, I think, are the Moderna and the Pfizer vaccines. Those have both already been licensed for use here in the US. Those are both mRNA vaccines. And what that means is that the manufacturers take a small piece of the genetic code of the COVID virus. It's a piece that codes for what's called the spike protein, and that is a piece of the virus that your body can then build antibodies to fight off COVID. That small piece of genetic material is encapsulated in a little fat molecule, and that is what you get when you get the vaccine. That mRNA then enters your cells, where your body can then turn that into spike protein. Your body can see that and then begin to make antibodies. One of the common concerns that I hear from people is whether or not this mRNA can actually get into your body and alter your DNA. So just to be 100% clear, your DNA exists in a portion of your cell called the nucleus. The mRNA from these vaccines does not enter the nucleus at all. So it is absolutely impossible for the mRNA vaccines to alter your own DNA. The other common vaccine types for COVID that are being explored and that should come to market soon are the Janssen Pharmaceutical or J&J vaccine and the AstraZeneca vaccine from the UK. And both of those vaccines are what we call adeno-associated viral vaccines. So what does that mean? So the adenovirus is a really common cold virus. What they do is they take this virus, they basically turn it into a virus that cannot replicate, so it can no longer make you sick. But they use it like a little secret Trojan horse to sneak the RNA from the COVID virus into your body, so your body can take that up, recognize it, and again, start making antibodies. So they package a piece of DNA that it codes for the spike protein into this now replication deficient adenovirus. That is what the vaccine is. You are given that through the vaccine. Because your body cells recognize the cold virus, the adenovirus, it will attach to that, therefore allowing that piece of genetic material into your cell. Again, your body creates its own spike protein that then your immune system recognizes, you make antibodies, and you develop immunity. So those are the main two types that are either on the market or coming to market. There are other types of vaccine platforms that are being researched and developed for COVID, but none of them seem like they're going to be coming to market anytime in the imminent future. Now I want to talk a little bit about the efficacy or the effectiveness of these vaccines. So we're very lucky, actually, in that the vaccines that are on market and coming to market are much more effective than I think anybody hoped they would be. Both the Pfizer and the Moderna vaccine have approximately 94 to 95% efficacy against preventing both mild, moderate, and severe disease. So that's amazing. And just recently, I think within the last few days, a study came out of Israel. So the 94 and 95% efficacy was the data that came out of basically the study trials looking at whether these vaccines could be marketed. Whenever a vaccine is marketed, we always have to see in a larger population if what we saw in the trials continues to be true on a grander scale. So the wonderful news is that on a grander scale now, we are getting feedback that these vaccines are actually as effective as they initially looked. The study from Israel came out and said that the Pfizer Moderna vaccine were at least 92% effective at preventing severe disease and hospitalization. That's awesome news. The J&J vaccine, which is the other one that should be licensed, as Gary was mentioning here in the next few weeks, hopefully, the adeno-associated viral vaccine, that is the one-dose vaccine. They've done trials and they've actually looked at this vaccine against what we think of as the original strain of COVID virus, and I'll talk a little bit about the variants, as well as the South African strain and the UK strain. So the studies done in the US showed an efficacy for moderate and severe disease of 72%. That meant that the J&J vaccine was 72% effective at preventing moderate and severe disease. When they looked at the efficacy in places like South America, where the Brazilian strain is circulating, and South Africa, where the South African strain is circulating, the efficacy rates were slightly lower, but still pretty good. In Latin America, Brazil, the efficacy was 66% for preventing severe, moderate, or severe disease, and in South Africa, it was 57%. Now, one of the main differences I'm sure you've all noted between the J&J vaccine and the Pfizer and Moderna vaccine is that the Pfizer and Moderna vaccine are a 2-dose series, whereas the J&J currently is being studied as a 1-dose series. So these efficacy rates were based on a 1-dose series. Currently, there are studies going on in the US by Johnson & Johnson looking at actually a 2-dose series as well of their vaccine to see if they get greater efficacy with a 2-dose series. So that information is still to come. Another piece of good news that came out about the J&J vaccine was that looking at these study populations, 48 days from vaccination, they actually saw rates approaching 100% for preventing severe disease and hospitalization, which when we're talking about what we really want from our vaccines for COVID, it would be wonderful if we can prevent people from getting any type of disease. However, what has been causing the main problem in our country and worldwide is the rates and the need for hospitalization, which has been overwhelming our medical system and leading to unnecessary death. So if these vaccines can, at the very least, prevent moderate, severe disease and hospitalization and death, we are on a wonderful path. Does that mean you may still get sick with a mild case of COVID? But yes, but if that means you're not needing to go to the hospital, needing the medications that Dr. Camby, Dr. Bernstein talked about, not needing ICU care, not needing to be intubated, not having to worry about loss of life for you or your loved ones, that is actually the main goal with our vaccination program. And looking at the data we have now, even with the variants that are out, we are very, very optimistic that that is what we're going to see. So far, even with the variants that have occurred, we have not seen an increase in rates of hospitalization or death for people who have been vaccine recipients from those strains. Let's discuss a little bit about how efficacious the vaccines are against those specific strains. Otherwise, we do know that it seems like for the UK strain, the vaccines are as effective as they were for what we think of as the original coronavirus. Now, I want to talk a little bit about mutations in viruses. So viruses mutate. That is actually very expected. It's not unusual. The influenza virus mutates on a much grander scale than the COVID virus is mutating. This is why we need a new influenza vaccine every single year. Not because you don't maintain immunity to the vaccine for the type of virus that you got last year. It's that the virus changes so quickly that last year's vaccine doesn't work for this year's vaccine. So many vaccine experts don't feel that there's a likelihood that the coronavirus will be as mutatable, I guess for lack of a better word, as the influenza virus. But that being said, even as it mutates, what we're really looking for again is what we call escape variants. The variants that escape the effectiveness of our vaccine. And what we're seeing is, again, for the UK variant, our vaccines are as effective. For the South African strain, they may be slightly less effective, but they do not seem to be less effective for moderate severe disease or hospitalization. And the same for the Brazilian strain, although it's very early for us and we're still collecting data on this. The next thing I wanted to talk about as far as vaccination was a little bit about asymptomatic transmission. So I'm sure a lot of people have heard one of the things that we were not able to tell in the initial studies on these vaccines was, while they prevented you from having symptomatic, mild, moderate, or severe disease, we weren't really certain whether they were preventing you from getting an asymptomatic infection that you could then pass on to another person. We are starting to get some data coming out about this, and the news is actually very good. It looks like these vaccines may be up to 85 to 90% effective in preventing asymptomatic transmission. So there's a study that just came out of the UK and some very early data out of Israel showing that. We will wait for more information, but if subsequent studies confirm this and uphold that, that's great news that this would prevent asymptomatic transmission so that a vaccinated person could not actually even have an asymptomatic infection they could then pass on. Finally, I want to talk a little bit about vaccine safety. And I know this is something that is on everybody's mind. So first thing I want everyone to know is that we have now given these vaccines on an incredibly large scale. Despite the fact we're actually not vaccinating as quickly as we want to, we've given over 65 million doses here in the US and over 200 million doses worldwide. In the US alone, we follow safety for vaccines, not just prior to marketing them in our studies, but post-marketing. And in the US, we are using 4 different systems to follow this safety. We are using the vSafe, the VAERS reporting system, which some people may have heard of, something called CISA, and the Vaccine Safety Database. So we are tracking within 4 different systems any reports of serious adverse events, looking for any signal that there may be a safety issue with any of these vaccines that did not show up in the initial trials. And the great news is we are seeing absolutely no signals whatsoever. They have looked at things like Guillain-Barré, pulmonary embolism, myocardial infarction, which is a heart attack, need for hospitalization, clotting problems, lowering of your platelets, a multitude of things, and we're seeing a signal in nothing. We've also collected data post-marketing on over 15,000 pregnant vaccinated women, and again, we are seeing no issues with safety for vaccination in pregnancy or with breastfeeding. A good rule of thumb also to understand is that when it comes to vaccination, typically a vaccine will not cause a side effect that the virus itself does not cause. So as an example, one of the things you may hear about with influenza vaccine is Guillain-Barré. However, influenza virus itself causes Guillain-Barré at a 17 times higher rate than the vaccination. Likewise, with the MMR vaccine, you can get a transient, which means a short time, lowering of your platelets, but the measles virus does that on its own and actually does it more frequently than the vaccine does. So we know we've had many, unfortunately, pregnant COVID patients, and we have not seen increased risks for birth defects or spontaneous abortion with COVID infected patients, and we are not seeing that with the vaccine. So that is also really great news. Finally, I want to talk a little bit about 2 other things. 1, anaphylaxis, and 3, people's concern about the quote unquote idea that this vaccine was rushed to market. So I'm going to talk about anaphylaxis first, and I'll close a little bit talking about the concept that this vaccine came out so quickly. As far as anaphylaxis goes, there was an early signal in the trials and the early administration that perhaps there were higher rates of anaphylaxis, which is a severe allergic reaction. That's what you think of when you think of someone eating a peanut and their face swelling and not being able to breathe and needing epinephrine, the medication that Dr. Canby mentioned. So as we have given more and more of these doses, the rates of anaphylaxis per million doses has continued to drop. So we're actually seeing the rates are not as high as we once were concerned. Initially, they were reporting rates for the Pfizer vaccine of about 11 cases per million doses, and now that is down to 5 cases per million doses. We actually expect that to continue to drop. For the Moderna vaccine, we initially were reporting 2.8 cases per million doses of vaccine. We are now reporting 2.5, and we expect that to continue to drop. And I always like to just give things for comparison so people can understand, well, how much of a risk is that? So a study in 2017 looking at 25 million vaccination doses in adults and children showed that for all vaccines, there's about a 1.3 rate of anaphylaxis per million doses. So being at 2.5 to 5, while it is higher, is not a substantially higher number. And then I like to compare it to something we think about with anaphylaxis on an everyday basis. So someone allergic to bee stings, if they get stung by a bee, has a 1 in 200 to a 1 in 20 chance of having anaphylaxis. And I would say that anyone allergic to bees wouldn't say they stay inside all summer because they don't want to get stung by a bee, right? Anaphylaxis is a completely treatable problem. This is why if you get your vaccine, you are monitored for at least 15 minutes. And for anyone with a history of severe allergy or anaphylaxis, they are monitored for 30 minutes because 90% of all of these anaphylactic reactions have occurred within 30 minutes. And again, it is 100% treatable while you're there. So I would recommend that no one feel unsafe getting this vaccine for fear of anaphylaxing. Lastly, I want to just talk a little bit about how we study vaccines, how they come to market, and why concerns over this vaccine being rushed can be, I'd like to allay those fears, I guess is what I'd like to say. So Dr. Canby touched a little bit on the concept of phase 2 trials. So typically when we study a drug or a vaccine, there are 3 trials, phase 1, phase 2, and phase 3. Phase 1 trials are very small. They typically last for anywhere from a week to a month. And what they're doing in that is just looking at what's the best dose of this medication or vaccine for the patients that doesn't cause too many side effects and also seems to be effective. Once they've determined that, We moved on to a phase 2 tryout, which has more people. Those usually last between 1 year and 4 years. During that time, we do collect more safety data, but we're really looking at duration of efficacy for vaccines during that time. How long are these vaccines going to protect you? And then we move on to phase 3 trials, which are the largest portion of the trial. Those trials typically have 30 to 40,000 people in them. And during that time, what we're really looking for is any signals on issues with safety data. So during the vaccine trials for COVID, the first thing I want to let people know is that mRNA vaccines, while they are new to market, is not a new technology. That's something we've been studying for between 15 and 30 years. So this is not a new technology that came up in the past year that people decided to try. We've been working on this for decades and actually have tried to make mRNA vaccines for Ebola virus and other viruses. This just happens to be the first one that came to market. Secondly, I'd like to let people know that our phase 3 trials, our safety portion of these trials, was done 100% as thoroughly as we would do any phase 3 trial on any vaccine. So again, I mentioned that typically a phase 3 trial will have 30 to 40,000 people in it. And that's exactly what they did for all of these vaccines. So I'm going to read off my list now. For Moderna, they had over 30,000 patients. For the Pfizer, they had 43,000 patients. And for J&J, they did 45,000 patients in their phase 3 trials. Those were done completely the way we would normally have done. And they waited for a full 2 months after the vaccines were given before applying for authorization. And that is because with any vaccination, any serious adverse event that is going to occur with the vaccination occurs within 6 weeks. That we know from our other vaccines. Vaccines are the most well-studied drug that we use, if you want to think of it as a treatment or a drug, that we use in our society. So our phase 3 trials were absolutely and completely thorough. Where we saved time was that they shortened the phase 2 trials, the trials looking at how long are these vaccines going to be efficacious. And I think we can all agree, we don't want to wait 3 years to find out if this vaccine will work for a year or 2 or 3 years. Too many people all over the world are dying. So they said, okay, we know this is safe. We know it's effective at least for a short period of time. We will continue to collect data on how long it will be effective after we start giving it to the public, knowing it is safe. And based on that data that we are going to now be able to collect on how long these vaccines are going to be efficacious for, will help guide us in knowing as we go forward, is this a vaccine that needs a booster every year, every 3 years? In addition, when it comes to variants, we know how to sequence the variants, just like we were able to sequence what we think of as the original coronavirus. And so if we need to make what we call a polyvalent vaccine, a vaccine that contains the mRNA for the spike protein from each variant, that's very easy to do. We do that with other vaccines that we already use routinely. In addition, we may find that just a booster dose down the line is enough to protect you from the variants without needing a new vaccine to be developed or a polyvalent vaccine to be developed. So again, I just want to reassure everybody, the concept that this was rushed to market, while I understand why it feels that way, all the important safety steps that we would use on any vaccine, on any drug, were all completely followed so that we can all feel safe from a safety standpoint, in addition to the fact that we now have almost 300 million vaccinated people worldwide and are seeing no signal for any serious issues for safety, which to me is even more reassuring. The last piece of information I want to say is that there's a gentleman, Morris Hillman, who is actually considered the father of vaccinology. He helped develop 9 of the 14 vaccines that are on our pediatric vaccination schedule. And what he used to say was that he was never comfortable until the first 3 million doses of a vaccine had gone out. Well, we are well past that point, and we are seeing no issues. So again, I hope that everyone will get out, get your vaccines when they're available to you, get us out of this pandemic so we can all start to enjoy each other's company. And just thank you to my fellow presenters, the CMHS Health, and I'll send it back to you, Deb.
Thanks, Sally, and thank you all for providing us with the latest update on COVID-19 in our community. So now we're going to turn our attention to the chat box for questions. And Gary, I'm going to start with you. And There are some questions about what the county plans, so I don't know if you'll know the answers, but does the county have any plans currently to vaccinate the unhoused or homeless and the people with disabilities that are homebound?
I'll separate those two. On homeless, it has been discussed by the county health department. They understand that's a vulnerable population. I don't know the details of that plan, but I do believe that public health nurses do plan to reach out to help vaccinate that vulnerable population. In terms of those that are homebound and confined, there are some plans. In fact, we have some plans also to outreach, coordinating with home healthcare companies. Some of our retired physicians have gotten together and they have volunteered to actually go to homes. We haven't mobilized that yet, but soon will. So there have been discussions. I don't know the detailed plans, but it is on the list and we will of course do those things.
Thank you, Gary. So next, Neil, there's a couple questions about monoclonal antibodies. One is, can asymptomatic people get monoclonal antibodies? If you test positive for COVID, how do you get those antibodies? And when will the CMH, when will they open the outpatient infusion center?
Good questions. So part of the emergency use authorization for the monoclonal antibodies is that you actually have to be symptomatic. So it is for symptomatic treatment. That is based on the EUA for that. So you have to be exhibiting some signs or symptoms. Otherwise, you really won't know when you contracted that. So it has to be given within the first 10 days of symptoms. So that is part of the requirement for the administration of the monoclonal antibodies. As far as the infusion center, that's been an ongoing process. We've been meeting on a weekly basis for the last 3 weeks, trying to make sure that that's up and running. I don't want to overpromise anything, but we're trying to have that ready to go in anticipation of this fourth wave. So to be perfectly honest, we've got the framework laid. We've got most of the staff willing to do it and the space available to do it. We're hoping by mid-March that we will have that available. So mid-March, kind of at the earliest, end of March at the latest. But again, kind of anticipation of that fourth wave.
Thanks, Neil. Bob, we're going to turn to you for a more technical question. Does BiPAP respiratory assistance help? And how low does the O2 sat get before a patient needs intubation?
Yeah, it's to answer the second question, I think it's a case-by-case basis, but just if with full non-invasive support, it means oxygen administered through a nasal cannula, often a high-flow nasal cannula, or with these non-invasive positive pressure devices, continuous positive airway pressure, CPAP, or bilevel positive airway pressure, BiPAP. If your oxygen level can't be maintained much above 90% and or the person is working hard to breathe or both, that's a time to intervene. As far as the role of respiratory assistance in COVID, it has evolved. I'll try to keep it brief. From the way of thinking, really in the pandemic, in this country, in Italy, and other countries throughout the world, the idea was to transition a patient who was requiring more than just a moderate flow of oxygen, 6 liters, and if they weren't making above 90, put them on the ventilator right away. And the pendulum swung back, and I think in a reasoned way, I think with good reason. I think we were probably intubating worldwide too many patients too fast, and they were having complications. And I think we have a more balanced approach now. So I still think that along those lines, intubation, invasive mechanical ventilation, using a breathing machine or respirator, is really a treatment of last resort because most people can get by without it. So the issue with BiPAP and CPAP that I have is that they certainly can act as a bridge to getting someone well. They can buy time. I think in a person who for a variety of reasons may want to forego invasive mechanical ventilation, it can be at least maintaining an adequate oxygen level. But the issue that you run into with these modes, and this technical question, I'll give you a technical answer, is that people often take too deep a breath. And the pressure, I should say, the volume, the amount of air that's entering the chest and the lungs is excessive. people don't have control over it. You're short of breath, your oxygen yourself low, you want to get as much air as possible. And in that process of getting air, it can over distend the lungs and actually irritate things and make things worse. So you'll get a different opinion from different pulmonary doctors, but we very selectively use CPAP and BiPAP. And frankly, if I'm thinking that someone has reached that point that just high flow oxygen isn't doing the job, and I'm thinking about CPAP and BiPAP, I often will cut straight to a ventilator under those circumstances because of the fact that we can't control volume, which can injure the lung further. So, to summarize, 90% or better, and selective use of CPAP and BiPAP can have a role.
Thanks, Bob. Gary, there's a question asking, how has the morale of the employees and physicians held up during the last year?
I think remarkably well, but it's been a long road. And we were particularly concerned about morale toward the end of December and through January when the volumes went up. People were stretched. We also had a rough spot where a number of people couldn't come to work because they had been exposed to family or friends, and so they were called off of work. So there were some stressful times. The hospital for the staff, and Debbie, as you know, you've led this for the medical staff, has recognized that there are some emotional and morale and so forth issues along for the caregivers as we take care of patients. But now people are seeing the light at the end of the tunnel. I think morale is very high. It's almost it's a joyous feeling as we see the numbers of COVID patients going down. And but I think given what we've gone through in the last year, I'm pleased to report that morale has been remarkably good, and I'm just so proud of our staff. So please, next.
Thank you. I definitely agree with that. Allie, there's a question that says, what do we know about children COVID vaccines under 10 to be exact?
That's a great question. So currently the Pfizer vaccine is licensed down to 16. The others are 18 and over, but there are trials going on right now for children down to the age of 12. So 16 and over can get the Pfizer vaccine. Again, studying down to the age of 12 for some of the vaccines. And my expectation is what they will do is they will slowly but surely, they'll study the 12 and above group. Once we show safety there, they'll lower that down to a slightly younger age, say 8 to 10, and go up. Unfortunately, I think that means most of our kids are not going to be getting vaccinated anytime soon. Maybe the end of the year, maybe next year. The good news for children is that we tend to see less severe disease in kids. Obviously, we would love to vaccinate them because what we all want is herd immunity. I didn't get to mention that, for the routine strain, we need at least 70% of the population vaccinated for herd immunity. With some of the variants, we're thinking even higher, maybe 85 or 90%. So we would love to have kids vaccinated. Again, right now, you have a child 16 and over. Once it's available to the public, they absolutely can get it. And I would say in the next 6 to 12 months, we'll see it down to younger ages like 10 to 12.
Thanks, Allie. So Neil, is using public transit or other non-owned transit dangerous now?
Is it dangerous now? I can't say with any numbers to back this up, but it comes down to the basic preventative measures, whether it's close proximity, hand hygiene, wearing a mask. If you can adhere to those and keep a safe distance of the 6 feet recommended distance, then transit like that I don't believe would be that much more riskier. I know they are doing what they can to sanitize in between. But again, it just comes down to the basic things that we're doing, which is hand hygiene, masking, and social distancing.
Thank you. Dr. Bernstein, so Bob, Will physicians and staff now have to continue to don protective gear every time someone comes in with potential pandemic symptoms, even if we hit herd immunity in this country?
Boy, that's a good question. So yeah, the implication is that once herd immunity is established, that the virus won't be circulating. It'll be uncommon. It'll be rare. I think I can look to a disease like tuberculosis, which is not terribly rare, but it's very uncommon. But if you think a person has it, you still want to take precautions. So the answer is I think that if someone has a respiratory illness in our current environment, even months or years from now, we're going to be taking precautions and donning and asking ourselves to minimize acquiring the infection, unless it disappears completely, which I'd love to see. But I think until that happens, or until that's a reality, I think being cautious makes sense.
Thanks. Allie, so what do you think about a response to a person who says, I never get the flu, so I don't feel I need the COVID vaccine?
Okay, well, first, I would say just because you've never had the flu doesn't mean you won't get it, so you should get your flu shot too, would be my answer. It's like saying I don't need a helmet because I never fall off my bike. I mean, it's an accident when it happens. You don't know ahead of time. Got to be careful. No, I mean, I genuinely think two things. Number one, I really do think everyone should get a flu shot every year. I get mine every year. I force everyone I love to get one every year. And so, but let's just say you're like, I don't get the flu shot because they've decided they don't ever want that. I still think they should get the COVID shot. Let's just say you're not so worried about yourself. I mean, herd immunity, again, requires all of us to work together. Just like all of us at the hospital system have been working together during this time, we rely on each other. People who have comorbidities, the people that Dr. Bernstein is taking care of who are high risk, they rely on the rest of us as well to help them not catch this. So if you don't want to do it just for yourself, do it for your grandmother, do it for your neighbor, do it for the, do it for the people you love and the people that love the people you love. That, I mean, yeah, that would be my thing. If you don't want to do it for yourself, do it for everybody. That's what, as a society, we have to take care of each other, I think, and that's a part of it. So
do it for me, right? I need you all to do it. So we're going to stick with you, Allie. There's a question here about how this vaccine is different than the traditional vaccines, and how the traditional vaccines are dead virus, and this one actually, I think they use the word messing with your body. So this one makes your body. So is this really, do we still call it a vaccine, and why isn't it dangerous?
So yes, so this is absolutely still a vaccine. So we actually all of our vaccines work slightly differently. So some of our vaccines are a specific purified protein that is made in the lab that is the same structure as a protein on a virus. And we give that again, so your body recognizes that protein, makes antibodies to it to protect you in case the real virus gets in your system. Other viruses we use are what we call live attenuated. So they take a live virus and they weaken it to the point where it cannot cause disease, but it's still actually the whole virus, and you get that. Otherwise are inactivated viruses. So they kill the virus and they give it to you. So there's actually a multitude of different platforms or types of vaccines we already have in use. This is still a vaccine. The only thing that's different with this is instead of giving you the actual protein, what we're doing is giving you the instructions to make the protein that you'll then respond to. That's the only difference. But again, like, this does not get into your nucleus. It does not get into your DNA. It cannot do any of that. You're making the protein in exactly the same place that your body makes all of its proteins. That protein then goes out Your immune system recognizes it, creates antibodies, just like any vaccine. So that is, yeah, so absolutely it is a vaccine. Certainly it is a new type of vaccine, but just as safe as any other vaccines.
Thanks. So Bob, I'm going to ask this to you because I know you know this answer well. The question is, I know you are a teaching hospital. Did your residents play a role in care?
The residents most certainly played a role in care, and when the call to duty was announced, they rose to the occasion. Yeah, it's part of the experience of not only this generation of trainees, graduate medical education trainees, but other generations before, when there's a public health or other urgent medical need, that they're part of the team, and it's valuable for everybody. I think it's a win-win for everybody. I think it's good for the community. It's good for patients in the hospital to have a physician who's often on site continuously, who looks out for the welfare of the patient, who helps, whom we can delegate work, and at the same time, and in caring for the patient, and it gives back to the resident because they learn a lot. One thing about COVID is that the residents have learned a lot about respiratory disease. They're all, we're all in it together. Many of them know at least as much as I know. Even though I have years of experience, that we were all experiencing this together. So as a team, the residents have been invaluable, I think, and certainly I'll have to say I'm grateful and really pleased with having our program here under these circumstances.
Thanks. Gary, there's a question about people under 65 without pre-existing conditions. I know you touched on the tiers. When do you think that population will be able to be vaccinated?
Yeah, the only answer I can give, because these rules are established by the state, and the state can't answer the question until they receive the supply that is hoped for. But it will be well after the middle of March and before the end of July, sometime in that range. And I can't answer it better because we don't know when the supply will come. But if I were to guess, and this is only a guess, I would say that by the middle of April, we'll be opening up our clinics to virtually anybody that is 16 and older. There might be a prioritization of those that are 45 to 64, but I think that it'll continue to get opened up to more and more of the population, and that's our hope, but we don't know exactly when.
Thanks. So I'm putting this one out to all of you. We'll see who knows the answer. Once you've been vaccinated, what are the odds that you can still transmit the virus to others? All right, Allie, I feel like we're playing a game show.
Oh, you guys caught me raising my hands like that on video. So again, we are just starting to get some preliminary information about this. The preliminary information looks very good for the vaccines being highly effective on preventing you from being vaccinated and being able to transmit anything to anybody. The idea, and I just want to make sure people understand, the idea is that you would be vaccinated, you would be around someone with COVID, you would catch the virus. I am using quotes, meaning you would pick it up and be carrying it. You would have no symptoms because you're vaccinated, so it's not causing you any disease, but that you would then be carrying the vaccine. Often we carry vaccines like this in our nose or in our mouth, and you would be able to then pass it on to someone. Okay, so that's what we call asymptomatic transmission. The early data coming out looks like these vaccines, the Pfizer, Moderna specifically, may be about 85 to 90% effective in preventing you from transmitting it asymptomatically, meaning there would be a small, but a very small chance you could. And we may get even better information. As we go along, it may turn out there 100% effective against preventing asymptomatic transmission. But right now it's looking like in the 80 to 90% range effective for preventing that, which is amazing.
Thank you. So Gary, this one came at the very beginning, so it may have just been a misunderstanding. It said, what do you mean that people can get at least one dose? Will second doses be held back?
No, second doses will not be held back. I was just referring to an article that I read, a commitment from the 3 major manufacturers that they would have enough supply for the residents of the United States by the end of July to at least have 1 dose. Those that only have the 1 dose would then get it in August. So that's what was meant by that. There will not be a withholding of the second dose.
Thanks. So I think the rest of all the questions are about vaccines. So Allie, you're on the hot seat here. There's a question about Guillain-Barré, and if someone has had Guillain-Barré previously, can they get the vaccine?
They can still get the vaccine. Again, they've looked to see if there's a signal for any increased risk of Guillain-Barré from the COVID vaccines, and they have seen that there is not an increased risk. So someone with Guillain-Barré can get the vaccines.
Allie, has anybody died from the vaccine in the United States?
That's a great question. So one of the things so the answer is no. That's the short answer. But let me remind people, so there's always going to be events that occur in a time associated fashion to anything, right? So someone is going to get this vaccine. We are primarily currently vaccinating older populations. Some of those patients, unfortunately, are going to be dying in the weeks or days or months coming after the vaccine, regardless, right? That is just a fact of life, unfortunately. So there's going to sometimes be a temporal or a time correlation to something like the vaccine. They have looked at this, and the data shows that with vaccine, population with vaccine, population without vaccine, the rates of death are not higher than you would expect in what we call the background population, meaning the rates of death in those populations are exactly what you would expect the rates to be in those populations at baseline. People are dying of heart attacks, strokes, exactly the way they normally would, not at a higher risk if they're getting the vaccine.
Thanks. So we really only have time for one more question, and we have about 4 questions that are really asking the same thing, and that's about boosters and when will we know if we're going to need a booster, and just what's the information we have about that at this point?
Great questions. I don't know. Nobody knows. Right now, I mean, so when we talked about the phase 2 trial that looks at how long the vaccines are efficacious for, and that's kind of where we cut time off and said, we're going to move this to market because we know it's safe. That's what we still have to find out. I think all of us can be a part of that as we go forward. You know, if there's a study out there looking for antibodies to COVID and you've been vaccinated, feel free to sign up for a clinical trial to follow that. That's what we're going to have to see. We don't really know. Same thing with booster doses for variants. We don't really know, is a booster dose going to help with that? Again, that's going to have to be, they're going to look at safety and efficacy for that as well, because we really do very carefully study these things. They may create another trial to look at patients who get a 3rd dose. Is that safe? And what kind of effect does that have on whether or not they catch a variant strain? So all of that is to be determined. I will happily come and talk again when we have that information, but we just don't have it now, unfortunately.
Thanks. Okay, well, this concludes our town hall meeting this evening. Again, thank you to our speakers for updating us on COVID-19 as it stands today, and thank you all for joining us tonight. Stay safe and good night.
Good night.